Hi everyone, today we read about small bowel enema, which is also known as enteroclysis. Following articles are described in the video and each discuss in detail. Introduction, anatomy of small intestine, methods, indications and contraindications, contrast medium and equipment, patient preparation, intubation technique, single contrast technique, double contrast technique, modification of technique, aftercare, complication, and advantages and disadvantages of small bowel enema. Small bowel enema is a specialized technique to visualize the jejunum and ileum with direct contrast installation via bilbo-daughter tube or silk tube at duodenojejunal junction. This tube is administered via oral route. Anatomy of small intestine. Extend from pyloric sphincter of stomach to ileocecal valve where it joins large intestine at right angle. Lies in abdominal cavity surrounding by large intestine. About 6.5 meter long and diameter gradually decreases from about 3.8 centimeter in proximal part to approximately 2.5 centimeter in distal part. Wall contains 4 layers: serosa, muscle layer, submucosa and mucosa. Mucosa contain finger-like projections called villi, divided into 3 portions: duodenum, jejunum and ileum. Duodenum, about 25 cm long and widest part, begun at pylorus and curves around the head of pancreas as C. Contain 4 portions: first superior, that is duodenal bulb; second descending part, that is common bile duct and pancreatic duct, usually units to form hepatopancreatic ampulla, which opens on greater duodenal papilla; third horizontal or inferior part; and fourth ascending, that is join jejunum at a sharp curve called duodenojejunal flexure and is supported by suspensory muscles of duodenum, that is ligament of Treitz. Jejunum and ileum. Jejunum is the middle section of small intestine and is about 2.5 meter long. Ileum is the terminal section about 4 meter long, lead into large intestine at ileocecal valve. I hope the audience understand the whole anatomy of the small intestine. Let's move on to the second part of the video. Usually this test is done in 2 ways: single contrast, which is also known as enteroclysis, and double contrast. Through exam is used to diagnose the following diseases and conditions: Crohn's disease, which is most common, pain, loss of weight, anemia, gastrointestinal bleeding, partial obstruction, malabsorption, that is dyspepsia, abdominal mass, suspected tubercular lesion, lesions such as strictures, neoplasm and Michel's diverticulum. In contraindication, barium follow-through exam cannot be performed in following condition and symptoms: complete bowel obstruction, suspected perforation, paralytic ileus, very ill patient or recently operated patient. In some departments, it is only performed in the case of an equivocal follow-through. Barium sulfate 100% water volume. This is diluted with tap water to give a volume of 1000 ml with a specific gravity of 1.3. The reduced viscosity produces better mucosal coating, and the reduced density permits the visualization of bowel loops which may otherwise have been obscured by a denser contrast medium in an overlying loop. In double contrast, an alternate way to gain a double contrast effect is to use a small 100 ml bolus of barium sulfate, followed by a continuous infusion of methyl cellulose, that is 100 ml of polygel made up to 2 liters with distilled water. In equipment, high power X-ray generator, spot film device, fluoroscopic unit with 2 TV screen, tilting type of X-ray table and overcouch X-ray tube is required. A choice of tubes is available: Bilbao daughter tube with a guide wire or silk tube. This is a 10 feet long or 140 centimeter long tube with a tungsten filled guide tips. Patient preparation: a low residue diet for 2 days before the examination. A laxative should be taken on the evening prior to the examination. NPO for 6 hours prior to the examination. If the patient is taking any antispasmodic drugs, they must be stopped 1 day prior to the examination. Amethocane Isenge 30 mg 30 minutes before the examination. Immediately before the examination, the pharynx is anesthetized with lignocaine spray. Preliminary film: plain abdominal film if a small bowel obstruction is suspected. Intubation technique: the patient sits on the edge of the X-ray table. The pharynx is anesthetized with lignocaine spray. The tube is then passed through nose or mouth with brief lateral screening. If per nasal approach is planned, the patency of nasal passage is checked by asking the patient to sniff with one nostril occluded. The silk tube should be passed with the guide wire, pre-lubricated and fully within the tube. For Bilbao daughter, the tube guide wire is usually introduced after the tube tip is in stomach. The patient is asked to swallow with neck flexed as the tube is passed through the pharynx. The tube is then advanced into the gastric antrum. The patient then lies down and the tube is passed into duodenum. Lie the patient on the left side so that the gastric air bubble rises to the antrum, thus straightening out the stomach. In the case of Bilbao daughter, tube introduced the guide wire. In the case of silk tube, lie the patient on the right side as the tube has a tungsten weighted guide tip which will then tend to fall towards antrum. Get the patient sit up to overcome the tendency of the tube to coil in the fundus of stomach. Metoclopramide 20 mg IV can be used. When the tip of the tube has been passed through pylorus, the guide wire tip is maintained at the pylorus and tube is passed over it along the duodenum to the level of ligament of Treats. The tube is passed as far as duodenojejunal flexure to diminish the risk of aspiration due to reflux of barium into stomach. Single contrast technique: barium is then run in quickly at the rate about 75 ml per minute, and spot films are taken off the barium column and its leading edge at the region of interest until the colon is reached. Fluoroscopy is performed during infusion and images are recorded using digital equations. 100 to 105 mm film or full size radiograph are required. Double contrast technique: methyl cellulose is infused continuously after initial bolus of barium until the barium has reached the colon. The tube is then withdrawn, aspirating any residual fluid in the stomach. Finally, prone and supine abdominal films are taken. Modification of technique. In patient with malabsorption, especially if an excess of fluid has been shown on the preliminary film, the volume of barium should be increased to 40 to 60 ml. Compression views of bowel loops should be obtained before obtaining double contrast. It is important to obtain the images of duodenum, and the catheter tip should be sited proximal to the ligament of treats. Aftercare. Nil orrery for 5 hours after the procedure. The patient should be warned that diarrhea may occur as a result of the large volume of fluid given. Complications. Aspiration, perforation of the bowel owing to manipulation of the guide wire. Advantages and disadvantages of small bowel enema. This procedure gives better visualization of the small bowel than that achieved by a barium follow-through, because rapid infusion of a large continuous column of contrast medium directly into the jejunum avoids segmentation of the barium column and does not allow time for flocculation to occur. Disadvantages. Intubation may be unpleasant for the patient and may occasionally prove difficult. It is also time consuming for the radiologist.